made it. You made it to the end of all the presentations. Congratulations. Every eye I look at is awake and open. That is great. Symposium tends to be a little bit of information overload. It is a lot all at once. There's not a great way around that, but we always like to preserve time for questions and answers. So what I'm actually doing is looking around and making sure all our speakers are within my line of sight. I will be acting as MC. As you ask questions, I will pick on audience members to answer. I'll repeat the question, and I trust people to vocalize loudly. Just a word, and we have a microphone in the back, perfect. So if you have a question, raise your hand, we'll get the microphone to you. Just a word of note about this, the first ground rule. It is fine to ask questions that are very specific to your personal situation. In general, the clinicians in the rooms will be unable to give specific medical advice on how to approach your situation for medical license reasons. So we will speak in generalities. If you ask a question that we feel is just way too specific, we'll say, see us after. So try and make it as general as we can. So with that in mind, I will open the floor to questions. And microphone's coming to you over here with Rebecca.
Hello, Deborah Macefield from Southern Utah. I'd like to ask the last gentleman about the physical, the ABRT, which I have done a form of and have been. I've had myelitis for 10 years, and since 2014, when I met Dr. Levy in Johns Hopkins, I found it in Southern Utah, and I've done it, and it's transformed my life. But just a quick question is that how, if I've noticed that if I don't, like if I've had an operation, I'm not allowed to work out or do stuff for 2 weeks, then I kind of go backwards. I figured it was a bit like a creased piece of paper that you always got to keep the weight on it to keep it flat. But as soon as you take the weight off, the crease comes back. So it's just a general, is that normal, or is that, does that kind of, will that eventually get better?
Yeah, Daniel, do you want to comment I think to say it a slightly different way is as you're doing rehabilitation, activity-based rehabilitation, or frankly any rehabilitation, if there are periods of times when you cannot follow the protocol and things seem to get worse, is that normal, and what's the basis of it, and do you expect for things to go right back once you restart? It's a great question.
Yeah, I mean, this is a very common problem that we see all the time. So people, while they're doing the program, they're doing quite well, and then for some reason, they stop doing it, and then things sort of taper down again. So that's why, as I said, this is sort of like taking your pill for high blood pressure. You have to have some degree of it in your program all the time. And that's why you also should see your rehab physician at regular intervals, because nobody can sustain these things on their own. When I have some patients I have to see every 2 to 3 months and get them sort of, we call it like crack the whip, right? Make sure you're going to do this again. And then, other people, I can do this once a year. So keep up the good work.
Yeah, we tell people there is definitely a use it or lose it phenomenon. The repetition is important. It gets easier. Yeah. And right next to you here.
Because this is an inflammatory response, is there any benefit to using anti-inflammatory drugs?
So because the illness is an inflammatory event,
Right.
Is there any benefit from using an anti-inflammatory? We're right near Dr. Banwell, so I don't know, Brenda, if you want to comment on this.
Well, I think the first thing is to be clear on what an anti-inflammatory is. So if in your mind you're thinking about things like Advil or naproxen or that family of medications, they don't appear to be effective when we're talking about inflammatory cells within the brain or the spinal cord or optic nerve. They might be very helpful if you have overuse muscle discomfort, or as you're going through rehab, there may be some days where you overdo it just a bit, and in that case, that can be quite helpful. But as a treatment for misdirected immune responses in the brain, these medications are not particularly useful for that. Corticosteroids, like prednisone and that family of medicine, those are anti-inflammatory therapies, and we do use them, as many of you know, especially acutely. And then the targeted treatments, many of the therapies that we use for multiple sclerosis or rituximab and that family of medicines that we use, for example, in neuromyelitis optica, those medications are immune modulatory, which means they change the behavior of the immune system, or immune suppressant, where they turn down the amount of immune activity. And those treatments are targeted specifically on the different conditions. Does that answer your question? Okay.
Okay, we'll come up front here. Who's got the microphone in the back? Roberta, front row. Does anyone here remember the Phil Donahue show, or is I? Yeah, okay, great. All right, we have our own version of Phil Donahue show.
So my question also is for Dr. Becker, and that is, when you talk about doing FES-type stimulation to these nerves and that you cannot maximize it, you could do it 24/7 to those cells, what about the muscle response? Do those muscles need time to recover from that stimulation that you're doing?
Yep. So certainly muscles need time to recover, especially when you start out new. And that's why you don't start an FES program on your own. You take the help of a professional. I have seen people that heard a talk like this and went out online and found an FES unit and started stimulating. You can, technically with the devices in the United States that are FDA approved, you can't really cause damage. But if our international visitors here, for example, if you're buying devices in Europe, including the UK, these devices can actually cause muscle injury. So you want to be careful when you do that. Overall, of course, like in physical therapy, the goal is you have to give your body some time to recover. And when you start out a program like this, you start slow. It might take 2 or 3 days in between for it to recover, and then you do your next bout. But overall, people will adapt to more and more stimulation that you can actually use it. And the other thing with the amount of electrostimulation to use, since it's very individualized, not everybody can tolerate certain amounts of it because it's still electricity. And if anybody ever touched like a cow fence, you can dial it up to a sensation like that. And we do it a lot in kids. And so with kids, it's a lot of fun because you have to actually distract them. So usually we play lots of games. If you go to pediatric physical therapy, occupational therapy, it looks more like, it doesn't look like work. But it is, because essentially you distract the children and then you slowly start increasing the amounts of electricity that they will tolerate, and over the course of several weeks, they will actually get to levels that will be working. What we like to see with FES is we want to see a contraction in the muscle. So just because it's tingling, it's usually not enough. Then you could just simply use a TENS unit. And we talked about TENS earlier today when we talked about pain. We want actually be able to induce a contraction, a visible contraction in that muscle that we're stimulating.
Okay, and right up front here.
Do you know what a power plate is?
I think you're referring to a vibration plate, right?
Yes, yes. Do you feel that vibration, and we have one of those, would be beneficial in what you're talking about?
So does anybody know what that is? So it's essentially a fairly large platform that vibrates at certain frequencies. For a couple of years, we were thinking that this could maybe replace some of the electrical stimulation component. We also were thinking maybe it puts more torsion on the bones to help with bone density loss. It's still sort of in its infancy. There are no large trials, and it has been very hard to use in patients' homes. For example, if you're living in a second-floor apartment, your neighbors above or below will not like you.
Well, we have it in our lower level,
Okay.
so we're good for
The
that.
whole house will shake. We didn't think that through when we got one in our therapy gym. We're on the 3rd floor and have a law office right underneath. So if anybody needs one, I have one.
So do we.
Okay, back here.
Hi, this is for Dr. Becker. And is the ABRT program coming up with neurologists who specialize in MS where I could go to them and ask him to set up a program even 8, 9 years after the onset, and see if we can get a new program along with FES started?
So your neurologist in general probably doesn't know a whole lot about rehabilitation. Am I right, Ben?
I think it's a fair statement, and it's worth just commenting. In general, actually, as a fact, as part of neurology residency training in America, there is no requirement to rotate on a rehabilitation floor as an in or outpatient. It's not a formal part of the recommended training for any neurologist, which is insane, but it's the case. What's interesting, and I think Daniel and the professionals in the room would agree, is depending on the practitioner, there are some practitioners in neurology who have spent more time learning from our rehabilitation colleagues. And I pose the question to Dr. Becker, are all physiatrists and rehabilitation professionals created equally in terms of their approach to the different therapies?
It's all very different. Physiatrists who are you will find physiatrists who are specializing in sports medicine. You see them in orthopedic medicine. So you really have to find the right person, and that can be very, very hard and frustrating. So just because you heard about this here today and you go to your therapist tomorrow, they may or may not know about this. Actually, odds are that they don't know about it is pretty high. So I recommend either coming to a center that does that. What we generally do, we help you create a program and then send you home with it. And then you can teach your local therapists. I mean, I have some patients who come to us, they bring their own physical therapists from wherever they are, and we teach them there, and then they continue that at home. If you don't have the luxury that you can do that, I recommend to approach, so you just go to your neurologist, get a prescription that says physical therapy, occupational therapy, eval and treat. So it's general, they can do anything. Then you call your local physical therapy or occupational therapy school, and you ask for one of the youngest therapists that's out there, who would be willing to work with you, or if you go to a physical therapy gym and say, get me in touch with the youngest ones, because they all learn it in school, but then it doesn't get cultivated. But if you find the young ones, they're still open to the process, and you say, I've read this, would you be able to help me use electrostimulation on a day-to-day life for me? And they also should be the ones who are actually deciding which equipment to buy. Because if you go out and go on the internet and just buy yourself a little box, they may not be able to use it. So you wait, the therapists have a device that they have been trained on at some point, and they will use that device to train you in the therapy gym, and that's the device you should buy.
Up front over here, Roberta can get you the mic. And while we're waiting on the microphone, this goes for both therapists, physiatrists, and neurologists. What we counsel patients about for any of the issues, it actually doesn't matter if your clinician is an expert. What matters is they're willing to partner up and look for resources and learn. So the centers around the country that are working with the TMA routinely get phone calls from other clinicians that we are happy to take as a professional courtesy and offer clinician-to-clinician advice. And so if you get somebody who's willing to make that call, we're happy to work with anybody to help get people the care they need.
This question is for any of the speakers. Do you have any knowledge about or experience with the development of 504 accommodation plans for those of us who are returning to the workforce in our careers?
Okay, so yes, I'm going to head to the back to Dr. Harder. Specifically, we're going to break into two parts. We'll talk about a 504 plan from the educational perspective and the school perspective, and then I'm going to pick on somebody else for workforce return. So.
All right, 504. So I mentioned earlier I do a lot of work with school, but I also, so that's usually K through 12. I do a lot of work with transition to college, so
Okay, so just move your lips and I'll interpret what you're saying. She says.
Thank you. So 504 accommodations are extended in higher education through the Americans with Disabilities Act of the ADA. And so that law says that individuals with disabilities may be eligible for accommodations. The things that I always like for people to know is these are accommodations, not modifications. And this plays no role in admission status, or it's not part of your record at the school. So at the end of it all, a diploma will mean the same thing for you as it does for everybody else. So those are some of the general things. In order to, I guess, qualify for those services, having an assessment, some documents from your providers, and going to the Office for Students with Disabilities, which you can find on any campus, that would be the route to get to that place. So.
And in terms of workplace accommodations, we'll send the microphone to the opposite side of the room to Anjali to comment on the work side of things.
Hi, I'm Anjali Fulber-Pratt. So in terms of workplace accommodations, yes, the 504 does still apply, although it takes on a slightly different meaning and role. So there's not an actual 504 plan like what Lana was talking about that you see in school. But all employers are required to accommodate disabilities based on what is deemed reasonable, and that's where it gets a little bit tricky. So typically the way that this works in the workplace is that after you have the job, or if you're re-entering the workplace, you would work with a representative from the human resources, so in HR, and you have to first disclose that disability to your employer before you can even start having this type of conversation. Depending on the employer, they may have internal paperwork that may involve getting letters from a physician in order to document that you're not just making up this disability, and things of that nature. But then I also routinely work with individuals of what do I even request in terms of an accommodation. So one of the challenges with a lot of the types of disabilities that are represented here in this room is I don't even know what it is that I may need in order to successfully reintegrate back into work and so forth. And again, like we've heard from many of the other professionals, it really does end up being a case-by-case basis. So for some individuals, it may be a flexible work schedule in order to, as you're readjusting to this disability and getting used to the medical management of it, but then easing it back into a more traditional work type schedule. Other things for me, it's making sure that my work desk and space is actually accessible for me, and emergency evacuation plans. I mean, all of those types of things fall under employment 504 accommodation. So I'd be happy to talk with anyone further about that, but that's kind of in a nutshell.
And it's worth mentioning, Anjali talked about the fact that sometimes you'll need documentation from clinicians. So just like neurologists never rotate with rehabilitation, there was not a single lecture in residency on how to fill out workplace accommodation forms. So you go to your neurologist and we just kind of make it up, and that's the honest answer. Some groups have focused more, and I don't know if Catherine has comments on this. Catherine Treadway, our social worker from UT Southwestern, worked with one of our practitioners to actually create a clinic that is set up to do evaluations for workplace accommodations or disability. And one of the issues we found is when you go to your doctor for a, quote, visit, there's a lot of things to deal with, a lot of things to do, pain issues, sleep issues, bowel bladder issues, depression issues, rehab issues, all sorts of things that by the time you get through all that to have a meaningful conversation about workplace accommodations, it just doesn't get the attention it needs. So one of the pieces of advice we'd give is set up appointments with your clinicians for only discussing that issue. And you go in and say, listen, there are a lot of things, but I want to carve out this time to figure out with you, here's my job description, what's medically reasonable, what are the things that we can put down, and document in their clinic note so that you can be supported in the process. Because depending on your employer, some of them want little documentation, some of them want a lot of documentation. So Brenda, do you have a comment on that?
Yeah, you can hear me, but one of the things that's incredibly helpful and empowering as busy clinicians is if you already know there are certain things you're going to need, write it out, bring it in so that your clinician already has something to start from. It saves a wealth of time. It allows you to have a template to work with. You know yourself really well. You've been to your workplace. You know what's there. You know there's stairs. You know there's barriers. You know the bathroom door handle doesn't fit what you might need. You know, whatever it is that you're going to
Great comment.
I run a nonprofit called Touch the Future, and we specialize in assistive technology and ADA and accessibility. But you can also contact the American Occupational Therapy Association and speak to tell them where you live and the work special interest section. There are over 3,000 OTs in that. That's what they do, is help you determine what you can do and what accommodations are, and that's free. So you can call 1-800-SAY-AOTA and contact someone in the work SIS, and then there's occupational therapists that can help you figure out what those needs are, or you can contact me at Touch the Future, and I may be able to kind of say, what work are you trying to do, and is it technology you're looking for, or an adaptive technique, or whatever.
That's a great point. Okay, we'll come back over onto this side. Microphone's right behind you. Yep, there you go.
Just another comment on the Back to Work program opportunities. The vocational rehabilitation programs in states also an opportunity that people can get in touch with, and that they can also help you with some of these programs.
And Catherine, anything we're leaving off the list in your experience?
Services should be free and at no cost. And one other resource that might help is the Job Accommodation Network. You can actually call, and they have attorneys on staff, and they'll help you write your letter. So you could just bring that letter to your physician and say, do you agree with this, and have them sign it. But they can help you construct that, and figure out what is reasonable maybe and what's not. Because that's what Anjali was saying. It's kind of vague, and they're supposed to provide reasonable accommodations, but if it's some hardship to them, they may not be able to.
Yeah. Other questions? Barbara.
Like maybe everybody else in here probably, I take a lot of medications and I don't want to take any extra ones if I don't need to. I've read a lot about vitamin D, and I'm not sure, there seems to be two sides of whether you need it or whether you don't. And also, I live in Arizona, and we get sun every single day. If you're outside a lot, isn't it better to get vitamin D from the sun? And do you think you really need it if you're in a place like, my doctors have been all over the map, like no, yes, maybe, whatever.
Sure. So I'll take prerogative and give you my answer first, and then maybe pick on Carlos or even Maureen or Mike. I know I've spent time on vitamin D. So a couple just evidence-based statements from what we know about vitamin D. So first off, it's important to recognize there are two forms of vitamin D that are being discussed in the world. There's vitamin D2 and D3. Vitamin D3 is what your body makes from the sun naturally. When it hits the skin, it changes a cholesterol molecule into what becomes vitamin D3. Vitamin D2 is what the US government fortified food with years ago to prevent rickets, a bone disease. Now, in most of the literature looking at the immunologic benefits of vitamin D, the data suggests that the benefit is from D3 and not D2. So you can drink as much milk and as much fortified foods as you want, but you may not get the immunologic benefits, if they exist, and I think they do, in terms of D3. Now, what about how you get to D3, the notion of sun exposure? There is evidence to suggest that 40 years ago, 20 minutes of sunlight a day would activate your D3, and that is not the case anymore. And there are a lot of theories as to why that has changed environmentally, and it's worth at least a beer or a glass of wine to go through them. But if you look at the difference across the north-south gradient from the equator up, it used to be the further away from the equator you got, the more vitamin D deficient you are. It's not the case anymore. Texans are just as vitamin D3 deficient as people in Minnesota. The sun isn't working the way it did back then. So we have to get it from dietary supplements. How many people's here, mother or grandmother, suggested a spoonful of cod liver oil? For anyone? Guess what? It's the highest source of vitamin D3 in the natural world, so grandma was right. And then you'll read all sorts of things. You'll hear salmon is high in D3. It is if it's wild salmon. Farm-raised salmon has almost no D3 in it. So in our clinic, what we say is there isn't a dose, because everybody absorbs it differently, there's a blood level we shoot for. So we start people on a supplement and we track the blood level. And our belief is that the higher your D3 level, anywhere from 50 to 100 nanograms per mil, the lower the risk of other autoimmune disease or recurrent attacks for the diseases we treat. Carlos, I don't know how, as you're counseling your patients about vitamin D3 supplementation or how to get it or what to do, what your thoughts are.
I think that you already covered very well the vitamin D, but again, there is one thing that there are a lot of unanswered questions about vitamin D, particularly because there is a potential concern, there are genetic susceptibility, and there are some either variations in the levels based on race. If you go to Latin America, where we are also exposed to a lot of sun, actually we see a lot of vitamin D deficiency. So I think that there are a lot of concerns that the vitamin D issue is a combination of a genetic factor as well as environmental factors and diet supplementation.
Yeah.
Can I just make a comment?
Where am I looking?
Vitamin D.
Yeah.
Also, just to remember, when you hear about it from like primary care doctors, vitamin D is kind of the hot vitamin lately. So, for example, Cincinnati Children's, the headache clinic gives vitamin D. I'm not sure how strong their evidence is. I've seen a lot of other patients put on it for kind of vague reasons, but usually by primary care doctors. So I'm not saying it doesn't have other benefits, but it's also kind of the hot vitamin right now. So yours is vitamin D. And, but when we're talking about it, we're talking about it specifically with respect to neuroinflammatory diseases.
Yeah. There was a lot of controversy about this maybe a year to 2 years ago when the Institute of Medicine came out with a report indicating that vitamin D was being overprescribed and overrecommended. And if you read the report very carefully, it didn't, I think, it accurately reflected in some of the reporting, was it said if you're trying to prevent osteoporosis, there's very clear evidence-based medicine that this is an appropriate therapy for prevention of osteoporosis. But if we're touting it as a prevention or cure for prostate cancer or prevention or cure for other diseases, we can't yet make that claim. And technically, based on level of evidence in terms of randomized prospective trials, we haven't had it, but the overwhelming evidence in autoimmunity says that the more deficient individuals have the higher rate of diagnosis or relapse. Brenda?
So comment. First of all, I think it's important to notice that it is recommended that every single individual living in, well, in the world, frankly, but certainly in North America, should be taking vitamin D as a daily ingestion. And the current recommendations I mentioned this morning currently are 800 international units per day. This is on the basis of the fact that 85% at least of children, and probably an equal number of adults, are currently vitamin D insufficient, as based on values that predict the risk of bone fracture and osteoporosis. Those values, as Ben was saying, we have no idea what number you need to have a better immune balance. That's never been quantified. But certainly, it's really important to notice that while it may be the hot vitamin to be being discussed, one of the reasons it's being discussed is because as a society, we have become profoundly vitamin D insufficient, and as a pediatrician, we're seeing rickets again in children in a country with this level of nutrition. And so this is not a small problem, and I do want to re-emphasize that vitamin D is a healthy thing to have in your diet. And as I mentioned earlier, even with the sun question, while I think people are more sun avoidant and are using sunscreen very wisely, and I advocate that, I think we do need to get vitamin D from a healthy supplement choice. So I do think we need to keep that in mind. When you look at immune cells and you take them from a patient and you look at how their cells behave if they're on vitamin D and if they aren't, it's different. And there is some suggestion that your immune cells are better regulated when you're on vitamin D. That's not curative, it's not enough on its own. But certainly the reverse, being really low in vitamin D, does not seem to be a wise choice if you have an immune disorder. So I think those are safe statements to right now. It's not magic, but I think being low is probably, generally speaking, ill-advised for everyone. And the final statement, quickly, if your vitamin D levels are really low, many people describe symptoms like muscle pain, fatigue, generally feeling unwell, bone pain. And when your levels are really low, you can experience all of those, and those symptoms can sometimes be treated by just bringing your vitamin D levels into the healthy range. So sometimes the problem is actually a very treatable one that you might not have thought about.
And I'll make a plug for tomorrow's session on alternative therapies, hosted by Dr. Alan Descent and myself. So in the war of which small session to go to, we will tell you which vitamin D supplement to take. Dun, dun, dun. I'm not going to tell you now. You got to come to the session to figure out which one. Carlos.
So since we are talking about vitamins, I encourage everybody also to check with the primary care doctor to make sure that the vitamin B12 levels are in the normal range. We frequently forget about vitamin B12, and vitamin B12 is perhaps one of the most important vitamins that are needed for neural repair and regeneration, and it's extremely important that everybody get a very good check at least every year on vitamin B12.
Well said. Okay. Next question. We'll come up here up front. You tell me and I'll repeat it? Okay. Okay.
In the study on cognition and MS with transverse myelitis, what were the medicines that the patients were taking? Were they taking gabapentin? I mean, what were the
So just to repeat it, in the study that you presented on cognition and transverse myelitis and multiple sclerosis, where medications were one of the concerns affecting cognition, which medicines were they on? And specifically, there was a question about gabapentin.
Very good question. So what I can tell you at this stage, so we have that information. It was not factored into that particular analysis that I shared. These were preliminary analysis we wanted to get out to this group. That said, the TM paper that we published a few years back, we did look very carefully at medications, and we looked at the participants who had cognitive impairment and looked to see were these the same patients on medication. We did the same thing for depression, actually. So we looked to see were the kids having cognitive impairment the same ones who are depressed. In both cases, we found that there was not a correlation there, but that is something that's on our mind and that we're tracking as a team to be sure we can account for that. Thank you.
Yeah, and I think this comes up for us as clinicians when there are concerns about cognition or fatigue, looking for medication side effects. So at a population level, it not being the causation for a trend at a population may be true, but for an individual, we have to look very carefully to see if side effects play a role. And I think this is fair to say it's true for fatigue and cognition. Those top two, we definitely look at medications. Yes, in the back.
Two quick questions, I think. At least they'll have quick answers. You can tell the cognitive part. Sorry. One, do some of these things like gabapentin lose their effect over time on their effect on, making you more comfortable with the pains, the shooting, the neuropathic pain? Okay. And two, can you take too much vitamin D?
So I'll do second question first and then ask Maureen to answer the first question on the neuropathic pain side. So yes, I think anything, so the question was, can you take too much vitamin D? I think there are levels of vitamin D circulating in the blood that start to get concerning for a risk of kidney stones or calcification of blood vessels. And so checking a blood level is the important part. There isn't a dose that is too much. It has to do with what enters your blood. So we have some patients who take 2,000 international units a day and they're fine. Some people who take 15,000 international units a day and they have the exact same blood levels. And so it's really a reflection of blood more than dose. So to turn things over to Maureen, the first question was, can your body become used to gabapentin, or in that case, any of the pain medicines for neuropathic pain over time, and they lose their efficacy over time?
In general, I would say no, they don't. They lose their, so oftentimes you get side effects when you first start a medication for neuropathic pain, and they lose that over time, but the good news is that their therapeutic effect doesn't tend to wane over time. Opioids are an exception to that, but in terms of the anti-epileptics and antidepressants, no, that doesn't tend to happen that I've seen.
Next question.
I just have a question about the myelin. When I was diagnosed with TM in December of 2015, I had many MRIs, and the virus did, strip the myelin. But my question is, I was told, I don't know who I could pose this to, but my neurologist had told me that the myelin sheath grows back millimeters a day. Is that true?
Mike Levy, do you want to comment on this? The notion of regrowth of myelin, and I'll intercede that there's differences in growth in the central versus peripheral nervous system, and that may be part of the conversation.
Yeah, that's exactly right. The nerves grow back outside of the spinal cord at a rate of about 1 millimeter per day. So if you have nerve damage, or if you have Guillain-Barré and there's nerve damage in the outside of the spinal cord, then we usually quote that 1 millimeter a day healing process. If inside the spinal cord, you may still get some healing, but it's not typically that type of rate. Good question.
Yeah. And one of the things that's worth noting about healing, at least in the central nervous system, we all know that every individual is different in terms of their healing capabilities. Some of us form scars in different ways, just on our skin and other parts of the body. There have been animal studies that have looked at the rate of myelin repair in a young mouse versus an older mouse, and it's different. And if you take the repairing cells from a young mouse and put these cells in the older mouse, they repair at the rate of the young mouse. So there is an internal clock to repair cells that age as we do. And so the reason when I'm at the children's hospital seeing kids with certain injuries, I can have prognostication at a certain level that is different than on the adult side, because in general, with the same injury, in general, kids repair to a different degree than adults. So we think there is a difference person to person and with age, at least in the central nervous system. There's a question over here. Yes?
All right, well, my question might be naive in me asking it, but is there like a limit on time of any, how long is the limit on any type of treatment for any nerve or spinal cord damage? Like, is there a time limit to how useful it would be versus, and this to any doctor in here that has any type of insight?
Yeah. No, I think it's a great question. I'm going to have Dr. Becker make a comment, because I think we get this question all the time about, are there time limits to the usefulness of different interventions? And before you answer, can I just ask one question of the audience? How many people here at the time of diagnosis or shortly after were told by such and such date what you get is all you're going to get, just by a show of hands? So at least half to maybe 2/3. Okay, so Dr. Becker. Were they advised correctly?
So the follow-up question is, in which cases was it true?
1. So we went from about 50 to 1. Okay.
So that's kind of the short answer to that. So there is no time limit. We used to give those time limits out, and actually people still are. If you even within Baltimore, where we are at. But overall, the nervous system never stops repairing. So it might be sometimes slower, sometimes faster, and we know that early on after an injury, it seems to be a faster pace, but it never stops. We have patients that have had injuries, 20, 30 years ago, and you start, you put them back into rehab, they get better. Generally what happens is, if you stop rehab, you kind of freeze your recovery in time. And this is probably where I think these numbers came from. Because if I tell you that, whatever you have recovered within a year or two, that's it. Then people say, okay, it's 2 years now, we're done. And so then you stop. And now you freeze everything that you've gained for these 2 years, because you're not doing anything. But if you get people back on a program, then you will see, we'll continue to regain recovery. So don't let anybody tell you that what you're at right now, that's it. That's not true.
Barbara has a comment. Yeah, so Barbara made the comment that despite being told that, even a decade later after the event, there was recovery happening. And so there isn't a window that closes. I think Daniel's correct. Yeah, I think when we're talking about things outside of rehabilitation, whether it's medicines or surgical procedures, for us it's a very case-by-case basis in terms of what's going to be useful. For us, is there any medicine or procedure that's off the table because of a certain time window? With few exceptions, no. But
there are some surgical procedures where the surgeons sort of draw lines in the sand where they say, until this point, we still do, for example, the prime example is nerve transfers or nerve grafting, where some people say, you only do it until so and so many years, and then after that they won't, but then, have other surgeries that could take place. But it's really, as Ben said, it's case by case, and it's pretty rare.
Yeah. I think there was a question waiting over here. Okay.
Does anyone have any knowledge about, I'm not sure who I would direct this to, brain mapping?
Brain mapping?
Yeah. I'm only asking because we were told by a neuropsychologist that my son could have brain mapping done, and if he has it done, they would be able to determine if there's some waves that they could help for neurofeedback. And it's different than biofeedback, I believe. Okay.
Well, we happen to have a neuropsychologist and a doctoral student in neuropsychology in the room. So and they're both looking at me like this. So I'm going to go with the graduate.
Rubbing my head and shaking it.
That's phrenology. This is different.
So I'm not familiar with any evidence-based brain mapping that is a tool. I never want to say that something isn't effective if A, I'm not familiar with it, or B, we just don't have the research yet. So oftentimes if families come in saying we tried X intervention and it really worked for us, I say great. But in this particular case with this question, I'm just not familiar. There are a few rehabilitation strategies that we know of in pediatric neuropsych and more that have been studied for adult brain-based medical conditions. The problem is, as I mentioned today in my talk, we haven't really studied these in these conditions. So we're a little bit at a loss in terms of what works for the conditions we're all here talking about. We hope to have more answers about that.
I never use whether or not insurance will cover something as the defining feature of does it work or not, because the number of denials I get for things that I want to do is so high, so it can't use that. But in this instance, if it were, I'll defer to Dr. Harder, but if it were a medical procedure, for example, or a drug or a surgery or treatment that was being discussed, what we would recommend to families is have that clinician either write out what it is and bring it to someone for a second opinion, just so they can sort through it, or have a clinician-to-clinician conversation with somebody you know and trust to see, does this at least seem as though there is justification for it.
Yeah, especially for something that's so expensive. We just would want for folks to use some caution and see what we know.
Yeah. And you've been waiting patiently. Yep.
Yeah, and I changed my question a little bit, but the whole, you've got your neurologist, and they say, well, mine did. And it was, okay, we've done all we can, so you just need to find a pain management doctor. Kind of, and not a procedural pain management doctor, because he said all those in his office were procedural. So went out on my own. I was very fortunate. I got a really good pain management doctor. And my question is, what about spinal cord stimulators? I had one 2 years ago, and I found a benefit of walking more than a half a block in pain to maybe a mile. So it was an improvement. I still turn it off and on sometimes when it annoys me, but anything, I haven't heard anything on a spinal cord stimulator.
Yeah, Janet, I don't know if you or Daniel want to comment in terms of the experiences you guys have had with stimulators.
So is everybody familiar with spinal cord stimulators? So essentially what you can do, you can disrupt the flow of information from the spinal cord to the brain by putting a little bit of an electrostimulation electrode right over your spinal cord. And it's fully implanted, it's underneath the skin. The patient generally has the ability to turn it on, to turn it off, to change the patterns. The reason why we have a lot of experience with those is because we're using them. Any insurance people in here?
This is being recorded. I'm just going to...
All
It
right.
will be online in
All right.
a few weeks.
All right, I'll tell you that later. So we're using them in our patients who have a lot of pain, because it's essentially electrostimulation as close to the spinal cord as you can get it. And so we have done about 10, 15 over the past a couple years. The effect is pretty dramatic in some patients. So the beauty of this is that you do not need medication by mouth. So there's no side effects of drowsiness or sleepiness or any other things. And but nobody just puts a stimulator in right away. So how this usually is done is you're going to get a epidural stimulator trial. So you go to an office, they put the wires in through your skin, and then they turn the device on and give you 2 or 3 days at home and see how you do. For anybody who wants to consider it, the magic number is 50%. So insurance companies will not pay for it unless they can document that your pain level is at least 50% improved, if anybody wants us. And so they have been very, very helpful for our patients.
All right, so we are going to bring it to last question for today. There will be more opportunities for questions for tomorrow, and then we'll talk about wrap up. So you've been waiting patiently over here.
Some of the talks have touched on the MOG antibody a little bit, but it doesn't seem to fit into any perfect box. It seems a little bit more new. Can someone address what kind of information or research is still ongoing with that, and what you can do when you find out you are anti-MOG positive?
So anti-MOG, I think, Brenda, if you're up for tag teaming this one while you're waiting for a mic. So in autoimmune disorders, there have been some where the causative antibody has been discovered. So there's a disease called myasthenia gravis, where most people have an antibody to something called the acetylcholine receptor, and they get weakness and double vision because of that antibody. In classically described neuromyelitis optica, the majority of patients, especially adults, have an antibody to the protein aquaporin 4, and the antibody seems to be causative of the neurologic events. And then over the years, there has been the identification of the anti-MOG, MOG antibody, that seemed to pop up in the literature in a lot of different places. Pediatric ADEM, and then later optic neuritis. And one of the problems, or one of the challenges with the research, as it turns out, is the way you test for the antibody has implications for the reliability of the assay. So in the early days, we could not get reproducible results till some very nice work at Oxford sorted out a reliable way to really test for the antibody. And now, at least in, Brenda has a ton of experience with in pediatric acute events. There are lots of kids who will have this antibody present and then it disappears. And then we're having some experience with kids and adults where the antibody is still there long after, and what are the risks for relapses. We think there are individuals who will have what looks like neuromyelitis optica, but instead of having the aquaporin 4 antibody, have the anti-MOG. It's just the number of people having relapses seem to be less if you have that antibody. Brenda, can you add to that?
Sure. So in addition to the discovery of new antibodies and making sure that the test that you're using is accurate, which has been a big hurdle, and things are now really coming online, and that's relevant because it's one of the reasons why you can't just go get this measured today. You might be able to on Monday.
Monday morning, you can get it measured. The test will be commercially available through the Mayo Clinic labs. They did not pay me to say that, but you can walk into your doctor's office and there is a code and they can send the antibody test to Mayo Clinic.
Right. And the reason that took such a long time is because people are very careful before something is commercially available, in other words, broadly available, that the test is identifying something that isn't present in the general population at any high frequency, and that it actually links with some kind of clinical disorder. That said, I think I mentioned in my talk earlier that there's about 100 of us meeting on Tuesday to talk about MOG for the entire day, because there's still a lot that we don't yet know about it. And one of the reasons for that is that when anything new comes along, you invariably find out about it based on who you tested initially. So at this point, we have looked at whether children with ADEM have MOG, and about half maybe do. But if you test them again 6 months later, the majority of those children no longer have those antibodies, and the vast majority of those children will never have another event. If you test somebody who had ADEM and now has a new episode of optic neuritis, or certainly if you have someone who's had optic neuritis multiple times, many of those patients appear to be positive. And then again, as Ben mentioned, if you test patients that look like they have neuromyelitis optica, but the aquaporin 4 test is negative, a number of those individuals will be positive for MOG. And so at this point, one of the reasons we all sound a little bit unclear is because we haven't tested everyone consistently and used the test to see, well, what does it predict? And what is it telling us when you test all comers? And that's about to happen. I think in the next 1 to 2 years, we will be much clearer on whether the MOG antibodies identify people at the time of their first event, and what does it mean then? What does it mean if you test someone much later, particularly if they're having a second event where it may mean something very different? And of course, most importantly for everyone in the room, if you have this antibody circulating in your blood, does it mean we should treat you differently? And at this point, I think we're rapidly trying to figure that out, because if it does, we want to be right on top of that. So we're getting there.
Yeah. And one of the reasons this part of the science, and for those of you who have been rolling up sleeves and getting your veins stuck across the hall, the reason this is important is sorting out the biology of these things is going to have major implications as we move forward therapeutically. We just had a paper accepted for publication from UT on a model, again in animals, that worked to selectively get rid of an anti-MOG antibody and leave the rest of the immune system intact. And so as we do the same thing for an anti-aquaporin 4 or something else, knowing what your biology is ultimately will lead to tailored therapies. And so it's a plug in a roundabout way for everybody who is willing and able to take part in any of the research going on anywhere, whether it's filling out a survey, rolling up your sleeve, answering a phone call. It goes a long way for us to be able to change what we do. So we're going to bring this evening part to a close. Brenda?